Good afternoon. So have you guys had a great day?
Yes.
Oh, that's wonderful. So they've asked me to come and talk to you about where we're headed. Looking at the future of nursing, how many of you have a sense of the IOM report, which came out in 2010? Institute of Medicine report on the future of nursing? Okay, so Institute of Medicine is a misnomer because it isn't really medicine, it's all of healthcare, and there are multiple professions in the Institute of Medicine. However, they are neutral and not politically affiliated with anyone, and so when they do work, it's very widely respected, and it is absolutely evidence-based. People have that? Okay. So, what happened in 2010 was that they came out with 8 recommendations for where they thought we ought to focus in terms of the future of nursing. The first one was scope of practice. Do I have any nurse practitioners in the room? There's at least one, okay. It's not just nurse practitioners though. It is also nurses in general in terms of their ability to function at the top of their scope of practice. Does that make sense to everybody? Are there people here who feel that you may not always do that? Yeah, I think so, yeah. And we've done low-hanging fruit in terms of the scope of practice, and that means the center led effort last legislative session in 2015 to fix the legal ramifications of scope of practice for nurse practitioners for new grads. Are people aware of something? You heard something in the news about that? So what we did was we went in and we changed the legislation because in fact you had to have 3,600 hours before you could practice unsupervised. And you had to be supervised by a physician, and you could not have prescriptive authority until all of that was handled. Is everybody clear about that? Yeah. So we went and we changed it, and we said you didn't have to be supervised by a physician, you could be supervised by an advanced practice nurse. Yes, okay. And so that was really incredible. We said you could have 1,000 hours, that's 6 months if you're working full time. Most people would like somebody to look over their shoulder for 6 months in a new role, wouldn't you agree? And then we said that you had prescriptive authority, thank you so much. We had prescriptive authority right away. Okay, so that was how we kind of handled that whole thing. Now, of the second one, the second recommendation of the 8 had to do with interprofessional practice. How many of you have heard discussions of interprofessional practice? Yeah, I mean it is the buzzword at this point. And the unfortunate thing, are there physicians here in this room? Okay. The unfortunate thing about it is that physicians think it's fine to have interprofessional practice as long as they're the boss. Not all of them, but it is an issue, okay? So we've been working very hard on interprofessional practice in the state and how do we create it and what kinds of things we do with it, which is really, really important. Then the third one has to do with residency programs for new grads. Now, how many of you in your facilities, you have some kind of a residency program for new grads? Many of you? Well, some of you. So that's a very valuable thing because, let me just be really clear. I don't care how many years you go to school for an RN license. I can assure you, you are not prepared to hit the ground running when you graduate. Is everybody clear about that? Yeah, so it just isn't working. And so we're coming up with strategies for how to do that differently. That's okay. We have a transition to practice and some other kinds of things that we're working on. So that's a part of it. Then the fourth thing, of course, is having BSN prepared nurses at the bedside taking care of patients. So how many of you in the room are BSN prepared or you're in school for your BSN? Okay, great. That's most of you, which is terrific. And I think that what it says to us is that the research is really very clear. The mortality morbidity rates drop with the percentage of BSNs increasing at the bedside, okay? There's no one who's a stronger proponent of associate degree programs than I am. And the reason I say that is because most of our minority nurses come up through associate degree programs because they're less expensive. Everybody got that one? And so I am very supportive of those. I don't want to see those eliminated. I really think it's valuable to have those. Okay, then the fifth one is doubling the number of doctorally prepared nurses in the country. Now with the new DNP programs, we're going to hit that one without much problem. But I do think we also need to increase the number of nurse researchers, and those are mostly PhDs, okay? The sixth one is lifelong learning. So here you guys are, right? Yeah. Lifelong learning. Is this not good stuff? Yeah. And what it means is we don't know everything when we graduate from college. And trust me, when I graduated from Indiana University in 1989, I thought I knew everything, okay? Everything. Well, you'll find out in a few minutes that I didn't. But at any rate, that's what I thought. And so it has taken me my whole career to figure out that it's all about lifelong learning. Some of it's formal academic learning, and the rest of it is all the other things we do in terms of learning, which includes these kinds of wonderful conferences, reading, you know, CE in your hospital, the whole thing, wherever you're working. So 7 then is about leadership. So how many of you in this room think of yourself as leaders? Oh yes, yes. Because my dear friend Angela Bear McBride absolutely is convinced that every nurse is a leader. Is everybody clear about that? So I get to reframe for those of you who didn't have your hands up. This is really, really important. In addition to that, there are some things that go with leadership, and we're going to talk more about those in just a few minutes, but the things that go with leadership are really about how it is that we are in the communities doing leadership things in the communities. And one of the things I want to assure you of is that we have a whole effort going on about nurses serving on boards in their communities. It could be the school board, could be the county health department, could be any one of a number of things, but they're really valuable things to be doing. And the last one is about data and data collection. And let me just tell you, Colorado is a disaster, okay? I mean, you guys go in and you renew your license and they may ask you 5 questions. But it doesn't give us like, when, you know, it doesn't give us the kinds of things we need in order to plan for the nursing workforce for the future. And that's really what we focus on at the center, is what's going on in terms of the nursing workforce for the state. So let me just do a little check here. What I'm learning is that we have a lot of new grads, right? And we have more than enough jobs for new grads. What are we missing? Experienced nurses. And in fact, I'm finding that there's all kinds of vacancies across the city, particularly in specialty areas such as critical care, ED, OR, labor and delivery. Is everybody clear about that? Yeah. I mean, and I can tell you on the coast, just so that you can decide where you want to go in your life, on the coast, East and West Coast, they're paying $125 an hour for experienced nurses in any one of those 4 specialty areas, and they cannot fill the positions. Is everybody clear about that? Now, I don't want to live on the West Coast, so it puts me at a disadvantage. But at any rate, just so that you're clear that that's the situation. Now, what I wanted to do now was to tell you, they've done, because the Robert Wood Johnson Foundation funded all of this work with the IOM, they've done sort of a halfway assessment. So we're 2015 now, and we have 5 more years before we see if we can make all of these commitments. And so now we want to find out where we are. And of course, we're not where we need to be. About half of the states in the United States have been able to increase the scope of practice for nurses. So we still have a long way to go in terms of that. We are in the process of transforming education, but not quickly enough, I don't think. And transforming education is all about how we teach you and what kinds of things that you learn. Because the true measure, if you will, of when you go to take your in-class exam is what is your level of critical thinking skills. That's the whole sum and substance of it. And I'm not sure we're doing the kind of job we really need to do in order to teach critical thinking. Collaborating and leading. That means we're in teams together, we're working together, and we're also having nurses lead those teams. Now we are fortunate at the center because we have a federal grant from HRSA, and we are looking at interprofessional team work in the FQHCs. You know, all the clinics. Is there an FQHC person? Yay. And the FQHGs are so important because they actually are the ones taking care of the medically underserved and indigent populations. And they really, the value that they offer and the contribution they make is phenomenal. So we have a program that we're doing to help people learn how to work as a team, and that's all the way from MAs in those clinics all the way up. Have you been to BSET? She's been to BSET. I love it. Okay. So collaborating then with one another so that you're much more effective is critically important. And just yesterday we submitted a follow-up HRSA grant, which has a whole focus on integrating behavioral health into teams in an effective way. And you guys just spent the last hour talking about behavioral health issues, which are critical to how we begin to move forward and provide care. Okay? And then the last one that they focused on was promoting diversity. I do see a couple of diverse faces in the room, which is very nice. However, let me be clear. We are anticipating that by 2035, 40% of the population of the state of Colorado will be Hispanic. Do you have any idea how many Hispanic nurses we have in the profession?
5%.
Not quite 5, it's about 4, 3 to 4. So it's not a good thing. Is everybody clear about that? Well, by the time we get to 2035, you guys are all going to be retired anyway, so it doesn't really matter. Oh, I forgot the 5th one, which is improving data. Now, we're working on that, but it's a real struggle. It is an incredible struggle. So we'll keep you posted as we push forward in terms of data. Now, as you can see, interest in implementing those recommendations in terms of our future as a profession has everything to do with people's what? Attitudes. It has everything to do with people's attitudes. Now, I'm speaking to the choir. You guys already think positively about learning and about how you give patient care because you're here sitting in the room. We don't have mandatory CE in the state of Colorado. So you're here because you want to learn something, not because you're going to get credits, although I think you're going to get credits. Yes, okay. Everybody's glad to hear that. Okay. But the whole business about attitude is really very, very interesting, so I just want to kind of expound on this for a couple minutes. People can have a what? A good or a positive attitude, or, and you know who they are, right? Yeah, you know who they are, okay. So some people then see the glass as half full, whereas others see the glass as half empty. Yeah, that's exactly right. And who do you want to spend time with? Yeah, people who see the glass as half full. Now, stachoma. Can anybody define stachoma for me? Okay, so I'm going to tell you, I'm going to share with you what stachoma is. So what I want to know is there anyone in this room who has never misplaced a set of these? Okay, sometimes a hand does go up, and I want to follow that person around. Because my whole life is about misplacing keys. And in fact, in the old days when we had narcotic keys, I used to walk out the door and go home with those things and get the phone call. I gotta bring them back. Okay, so keys are really a big deal. And so when my boys were little, well they're old now, but when they were little, I was at PSL downtown, and I'd be getting ready in the morning, I'd be running around and trying to get the kids ready, and I would be looking and I could not find the keys. And so I would make an announcement. Mom can't find her keys. That's a message. Come and help Mom find her keys. And so the boys would kind of scurry around. Pretty soon, my husband of 47 years, Sweet Walter, would yell down from down upstairs, "Did you look on the countertop?" Of course I looked on the countertop. That's the first place I looked. And so 5 minutes later, he would come down. I'm still looking for my keys. And in fact, he walks over to the countertop, and what's there? The keys. Because you see, when we deliver our brain a message, it believes us. The brain cannot take a joke. So when I say I can't find my keys, I can look straight at the keys and I don't see them because I've already told the brain I cannot find my keys. Does that make sense? That's stachoma. not seeing the obvious. Okay? So the real issue here is the messages that we give ourselves are critically important. How many of you have a little voice up there that says to you, well, that certainly was a stupid thing to do? I'm not the only one, right? Oh, okay, good. So everybody has a little voice like that, and this one always tells me I can't find my keys. And so it is very important, the messages that we give, because the brain believes it. Now, I have a very dear friend, a psych nurse, who tells me this is called psychosclerosis, or hardening of the attitude. And so you want to be really careful which way you harden it, okay? Hardening of the attitude. Now, I will tell you that sometimes we are in positions where not everything is rosy and perfect in our workplace. Would you agree with that? Okay. So I brought along my, let me see, just a minute before I do that. I just want to be sure that you guys are clear that things are shifting a great deal in terms of leadership as we're into the 21st century. And what I want you to know now is that in the 20th century, when I was coming up as a sweet young thing, leaders were, you know, the head nurse, I was the head nurse, and we were managers. We were the boss, the decision maker, the supervisor, the traffic cop, we were the delegator, okay? It's changed. Well, in good places it's changed. And so now we're the coach, the facilitator, the servant leader, the role model, and the visionary. See how different those are? They're very, very different, okay? So not every place is wonderful, but I want to talk about these today in terms of what leaders do versus what leaders are, okay? And so what leaders do is they create a vision, they build trust among those who they're working with, their team, they empower the members of the team, they coach, they get results, and they acknowledge people. Now, I'm not going to have time to do all of them right now, so I'm going to do just a few of them, okay? Visioning. First of all, you have to create a vision, and with that, you have to know what your purpose is. It has to be clear, well-defined, positive, and inspiring. Does that make sense to everybody? Because you're enrolling people in that vision. And enrolling is very important. And this is what enrolling looks like. Enrolling is about creating a brightness of the future. There always is a frequency of interaction, and there are believable alternatives. So let me tell you a little story about enrolling in a vision. When I finished my PhD, of course I was unemployed for a year. Most PhDs are unemployed for a year. I finally got this wonderful job at Press St. Luke's as the Director of Women's and Children's Services downtown. Okay. And they brought me in because they were one of the first 4 LDRPs in the United States. For those of you who haven't had a baby recently, an LDRP is you labor, deliver, recover, and have your postpartum stay all in the same place so that you don't move, the staff moves, okay? So it wasn't going so well, and they decided they wanted Kowalski to come in and fix it, right? Okay. So I'm buzzing along, you know, doing all these wonderful things, and I get to the end of July, and I look at the budget for the first time. I've been there about 6 weeks, okay? And the fiscal year goes from September 1 to August 31. And as I look at this budget, it occurs to me that if we don't do 150 births in the month of August, we will not make budget. Okay? So I thought, okay, how am I going to help everybody understand that we really have to do 150 births? And so I decided that we would envision 150 births. This is a good thing, right? So I have stickers made, 150 births. I put them on all the phones. I put them on all the Cardexes. This is before HIPAA. So on the delivery board, I put my United Way barometer, right? I had it measured off for 31 days. I knew exactly how many births we had to do each day in order to make 150, all right? So I went home for the weekend. I'd come back, there's graffiti on my barometer. I got it, they were not enrolled. Now, I'm an early morning person, so I would go in about 6 in the morning and I'd make rounds. Who do you see at 6 o'clock? The night shift, yes! And at 6 a.m. they'd tell me everything. So, I'm sitting there at the desk and there's this crusty old night nurse and I said, wow, I got it, you guys, you're really not enrolled in this whole thing. And she looked at me in a very crusty way and she said, so, what's in it for us? I'm going, my brain's spinning about 60 miles an hour, and I said, okay, I'll tell you what. If we do 150-person August, I will bring in fresh Gulf shrimp for everyone. I'll make Sweet Walter go out, dig up the horseradish. He'll make fresh horseradish. We'll do all the accompaniments. We'll have a great time. And she goes, huh. So how many births do you think we did?
150.
We did 165. Now, where did they come from? Did I have somebody out on the street corner with a hook dragging in pregnant women? No. You see, we had physicians who were what we called split admitters, which meant some of their patients came to our hospital and other patients went to the hospital down the street. So, what do you think the nurses did? They enrolled the physicians in shrimp. So we're sitting there eating our shrimp, right? I'm true to my word. And there's the crusty old night nurse. Now I have to tell you, shrimp was pretty tough at 6 o'clock in the morning, but that's the way it is, okay? She's sitting there, she's having shrimp, she's loving it, and she looks at me and she says, so, what's it take to get lobster? I said, 200. When we hit 185, I went down to the CEO, who didn't like me very much. I went down to the CEO and I said, I have this little story I want to tell you. And he said, if you do 200 births, he said, if you do 200 births, I'll buy the lobster. Did I enroll him? Yes. So it's important to be able to enroll in the vision. And do you get that there's a believable alternative? The nurses were very smart. They knew that if we didn't do 150 births, we were going to get positions cut, didn't they? Of course they did. It was a lot more fun to think about it in terms of shrimp. Yeah. Enroll in the vision. Okay. Leaders build trust. So let's look at this in terms of, the first thing is that you have to be reasonable and accountable and responsible. Does that make sense to everybody? So, and I'm going to talk about this in just a minute. And reliable, and predictable, persistent, and you have to have some expertise. So that's some of the things that it takes to build trust. Now, when we went to LDRPs, one of the things that happened was that we changed from having cesarean sections done in the main OR to doing them on labor delivery, okay? I mean, everybody does that today, but this was a new thing, and how happy was the staff that we were going to do OR? Not happy, you got it. And so I said to the clin spec, I said, oh, Cindy, let's open a tray of instruments and see what I remember. And I remembered all of them except Adson forceps. And she said, she says, I think you ought to scrub with me. Well, we're gonna get this done. I said, okay. So I scrubbed about 3 times with her, and she said, you're good to go. I said, great. Who loved it that I scrubbed? The staff. Because when the going got really busy, they knew that they could call me and I would come and help, right? It really makes a huge difference. Who else loved it? The docs. Their perception was when things were bad, down in the trenches, there was Kowalski right there with them. And of course the other part of it is if we were having trouble with a physician, I was often known to scrub. And when they saw me at the scrub stick when they came in, they'd say, am I in trouble? And I'd say, I don't know, let's find out. you can see that it's really important to be reliable and predictable and the things that go with that. Okay, so the other thing that today we do as leaders is we coach. All right? And what does that look like? Well, you have to have a relationship with someone that you're coaching. You've got to be able to ask really great questions. You have to acknowledge people. We'll talk about that in a minute. And you have to interact with your people. You have to create family, a sense of family, and a very civil workplace. Has anybody in the room heard our person Deb Center talk about civility? Oh, you gotta have her come and talk about civility. So anyway, it's a really, really important thing because that's what makes a difference in terms of being able to be a team, is that you have people who are able to work together in a positive and enlightened way. Okay. And then the other thing that I chose to say to you this afternoon is about acknowledgement. Now I have to tell you, I'm a Magnet Hospital appraiser. Anybody here doesn't know Magnet? Okay. I'm a Magnet Hospital appraiser, so I see hospitals all around the country. And you know, you do the employee satisfaction tool, right? Okay. So there's on every single one of them, and there's 4 or 5 different ones, but on all of them, there is a question that says, my boss has acknowledged me in the last 30 days. Right? Okay. That's the lowest question. It has the lowest rank. It's always at the bottom. Always at the bottom. Now, I also teach frontline leaders, you know, nurse managers, so forth. I say, do you acknowledge your people? And they say, every day. This is not making a lot of sense to me. And so as I began to think about this, I got really clear that there's some serious problems about acknowledgement and how it is done. How it is done. And so one of the things I figured out is when we acknowledge people, we must be specific. We cannot do what I call the Lawrence Welk form of acknowledgement. Thank you very much, ladies and gentlemen. No, it doesn't work. I think there's some of you in the room who don't know who Lawrence Welk is. That's because you haven't been in long-term care, because every Saturday night at 6 o'clock on PBS, we have Lawrence Welk. He's been dead for 20 years. It doesn't matter. Okay. It must be eye to eye. You must be able to look somebody in the face and thank them specifically for what you appreciate. It has to be from the heart. It has to be in sync with the event. In other words, you can't wait 6 weeks and then acknowledge someone. It has to be as close to the event as possible and public when possible. Now, I have a homework assignment for you. I want you to find somebody tonight and acknowledge them using the 5 rules of acknowledgement. Is everybody willing to do the best they can? Okay, great. That's great. All right. Now, not every place is like this, okay? So I brought one of my favorite sets of slides today called Riding a Dead Horse. Ancient wisdom says that when you discover you're riding a dead horse, the best strategy is to dismount. However, in organizations, we often try many other strategies, including the following: changing riders, obtaining or buying a stronger whip, believing the minority opinion that the horse is still alive, falling back on this is the way we've always ridden, creating training sessions to improve riding skills, changing the requirements so that the horse no longer meets the standard of death, appoint a committee to study the dead horse, arrange a visit to other sites to see how they ride dead horses, hiring an external consultant to show how a dead horse may be ridden, harnessing several dead horses together to increase their speed, increasing funding to improve the horse's performance, or declaring a dead horse less costly than a live one. You could always form a committee to find uses for the dead horse, or you could promote the dead horse to a supervisory position. I can see some of you have been there. Okay. So the second half of this this whole thing is about characteristics of leadership. And so there are 4 that I'm going to talk about today, which is character, commitment, caring, and confidence. And I'm not sure where I am on time. You're good. I'm good, okay, good, all right. So let's talk for just a minute about character, because character can be defined as who we are and what we do when no one else can see, when no one will discover what we think or do. So it's the core, okay? It's the inner form that makes anyone, anything, a person, a line, a historical period. That's the character. Now, a lot of research has been done by a guy by the name of Os Guinness about character, and so we're going to look at that just for a minute because I think it's helpful. Obviously, character evolves as you grow, right? And so it's based on standards or beliefs and values. Where do you get those? Family? Yeah. We had some very specific in school. You get them in school. We have some very specific ones in nursing school, do we not? Yeah, oh yeah, okay. So we've got some very clear standards, beliefs, and values. And then the second thing he talks about is the capacity for change and growth. In other words, when you're presented with evidence, you can change your mind. The third one then is moral accountability to the standards or beliefs that you have identified, that you value. So you have to be able to walk the talk, okay? Recognize destructive behaviors. That's sort of like just say no. Does everybody think they have at least one? Yeah, I have several, but I'm really pretty clear about one of them, which is when I blow my stack. It doesn't work, okay? And so I've worked very hard at decreasing the number of times that that happens. But at any rate, I still yell at Sweet Walter, but that's because we've been together for so many years. Okay. Forgiveness. Okay? Forgiveness. Now, I have to tell you, I'm the kind of person that I forgive pretty much anybody, anything, right? I mean, I may blow my stack, but then I'm done with it and I just move on. And but some people don't do that. Do you know people who hold on to grievances? Oh yeah. And whine about, never mind, okay. However, the thing that's toughest for me is forgiving myself. Who's the hardest person on you? Yeah. Well, I happen to be Episcopalian, and sometimes I kind of refer that to as Catholic light. Now, the Episcopalians do things a little bit differently because, you know, as the Catholics give something up for Lent, right? Chocolate or wine or whatever. Well, the Episcopalians take things on. So 5 consecutive Lenten seasons, I studied self-forgiveness. That's because I'm a slow learner, you know. I mean, this is not easy stuff. And I still work on it all the time because I'm so hard on myself. And then the last one he says is to cultivate humility. I think, particularly in politics today, it would be nice if we had a little more humility. Sorry, that was, I won't say anymore. Okay, commitment. It's important that we have commitment. And what does a commitment look like? Well, it looks like a passion, a fire in the heart. It's a willingness to do whatever it takes to accomplish the goal, whatever that happens to be. Now, Sweet Walter says the difference between a successful person and others is not a lack of knowledge or skills, but rather a lack of commitment. Now, I have to say, nurses, in my experience, have a huge level of commitment. I mean, we do things that nobody else in the world would do. So I'm not so worried about commitment in all of you. And think about, are you truly committed to what you're doing right now? If not, it's okay to change, all right? Okay. Caring, compassion. So how I talk about this is leaders simply care about more people. And what does that really look like? Well, caring is risking being with someone and feeling their pain. Healing can emerge from this kind of an experience. And see, we are with people who are experiencing physical and psychological pain every single day when we go to work. What a phenomenal demonstration of caring that is, to be able to be with them, to be with their families. And some of them, I was laughing at, I don't know, what was the doctor's name who preceded me? Yeah, okay, well, I was struck by, I was struck by many of the things that he said, but at any rate, I really got that there's some ugly people out there. I won't call them what he called them, but whatever. Okay. So caring really is giving of yourself, all right? And that means giving of your time, being 100% present, and honoring the person, their possibilities, their hopes, and their dreams. And I learned this probably most specifically as a doctoral student, because my dissertation was on social networks that support or inhibit the bereavement process in families who have stillborns and neonates that die. And what I got was how important it was to be absolutely 100% present for them. You cannot do your shopping list in your head. You have to listen, and you have to be with that other human being in their pain, their emotional pain, okay? And then the last one we're going to talk about is confidence. And I think I end with this because I think it's tough sometimes for nurses to feel really confident. And the greatest deterrent to confidence is what? Fear, absolutely. It's fear. So what does that look like? False evidence appearing real. That's fear. Okay? In addition to that, there's a wonderful book called Feel the Fear and Do It Anyway. It was written by Susan Jeffers in the 80s. Oh, somebody's read it. I love it. You can still find it at Barnes & Noble's. It's on the shelf. That's how powerful this particular book is. And she talks about levels of fear. So this first one is fear of what happens to us. So we might get sick, we might be in an accident, you know, we might, people we know might die. I mean, there's all kinds of things that happen to us that we're afraid of or anxious about. We also actually choose things sometimes that are anxiety producing. Would you believe that? Like going back to school. So there's a lot of things that we choose that we're scared to death of, and then we do them anyway because we know that we need to do that. Okay, so that's the what happens to us level. And the second level then is ego-related fears. And that's looking bad or, you know, not being what you think you ought to be. It's all of that ego-related stuff that gets in our way in terms of our confidence and feeling that we really can accomplish what we want to accomplish. And then the last one is I can't handle it. Now, when Sweet Walter and I first did this exercise about fear, we started talking about, you know, what is it, how does it manifest in our lives? And so I don't know what you say to your kids when they leave the house, but I said to him, you know, when the kids leave the house every day, we always say to them, be careful. That's right. So what's the message in be careful? One, the world is a terrible place. We're pretty clear you are unprepared. If anything should happen to you, I can't handle it. Right? I mean, that's the message. Okay. So we decided we wanted to change the message, and we were trying to figure out what we were going to do. And so Sweet Walter says, how about take a risk today? And I said, I don't think so. Instead, I said, well, how about if we focus on learn something new today? Learn something new today. Now, you may think this whole thing about confidence is really pretty easy. And the truth is, you develop it over time, and I had to look back at earlier experiences in order to sort of come to grips with this whole thing in terms of confidence. And so I'm going to close with a story that some of you have heard me tell before, so you can take a nap if you would like. You see, when I graduated from Indiana University, I got the last job in labor and delivery, right? And I was there with the permanent night nurse, and she was wonderful. She taught me everything. And when we got to the holidays, she had a family, and so I said, you know, take Christmas, I'll take New Year's. So I ended up on New Year's Eve at a party with the Army nurse recruiter. And after a few adult beverages, She convinced me I should join the Army and see the world. Well, after a few more adult beverages, she convinced me I should take a guaranteed assignment to Vietnam. So in April, I'm at Fort Sam Houston. I'm learning really important things. I'm learning how to salute, how to march, how many men in a battalion. I actually low crawled under live ammunition with an M1 carbine between my elbows and survived. This is really good stuff. You're going to the combat zone. What I did, we only had 3 days at Brooke Army Medical Center, and during that 3-day period of time, no one ever asked me what my skill set was. And in fact, at Indiana University, we had the largest, at that point, had the largest medical school class in the country, and nurses weren't allowed to do anything that interfered with medical education. So I'd never started an IV, and I'd never drawn a tube of blood.
Oh no!
Next thing I know, I'm on an airplane. I land in Saigon. This other second lieutenant who's been in basic with me says, wonder where they're going to put us. I said, I have no idea. They decided that we should go to a surgical hospital. Now, for those of you who don't know, in the combat zone, surgical hospitals receive only battle casualties. So they put us in a sedan and drove us up Highway 130 miles to Benoit. Benoit was where the Air Force Base was. All of the sorties were that were flown in the South came out of Benoit. There were a dozen fighter squadrons, and our hospital was in the middle of the 173rd Airborne Brigade, whose job it was to defend the air base. We get to the gate, and the snappy little MP is there, and he salutes, and he's very clever because he knows if it's a sedan, it's either a high-ranking officer, or if this is his lucky day, it might be female. Because you see, while I was there were 500 American women and 500,000 American men. So he leans over, he looks inside, and he stands up, he salutes, he says, "Afternoon, ma'ams," and he proceeds to tell us his name, where we might find him, and if there's anything at all we need, we should let him know. And I said, right. He steps back, signals us through, salutes snappily and says, "Can do." Now what they forgot to tell me in basic training is that units that have very high esprit de corps put little sayings on the end of salutes and radio messages and memos. The 173rd is the CanDo Brigade. We drove in. The chief nurse met us. She said, "Dump your duffel bags in the tent. Come on down. It's 5 o'clock by that time. Everybody's at dinner. I'll introduce you to everyone." We said, "Great." We are saying hi and bye. We're meeting all the docs, all the nurses. I hear this unbelievably grating sound, which I later found out is a field phone. And then the mess sergeant yells out, "Incoming wounded!" Well, I just sat there. And the chief nurse said, "Well, come on." And I said, "You don't understand. I deliver babies." She was not amused. She took me by the arm up to the pre-op area. When we got up there, what we discovered was there weren't just a few incoming wounded. There had been a major firefight, and there were more than 30. And she said to the sergeant, she said, call down to headquarters battalion of the 173rd and tell them the 3rd surge needs blood. Now, I had no clue at that point that in the combat zone, the blood bank is ambulatory. She turns to me and she says, Lieutenant, you're in charge of drawing off 50 units of fresh whole blood. And I said, what? You've got to be kidding me. I look over on the other side of the pre-op area, and there's this little spec Ford. He's throwing up sawhorses, putting out litters, hanging IV poles and plastic bags, and I thought, holy cow, he knows what he's doing. I'm sticking with him. We're working. Pretty soon, I hear trucks. I went over to the back door, I opened, I look outside, and here are 2 huge Deucenaires. And they're backing up to the door. Leaping out of the back of these 2 trucks were kids. 17, 18, 19 years old, and they were covered in red mud from the bottoms of their boots to the tops of their helmets. I looked at them, I looked at this clean cement floor, and in an instant, my mother came to me. And I said, where have you boys been? And this little PFC stepped up and he saluted me, snapped. He says, ma'am, we've been out in the rice paddies for 30 days. We've been chasing Charlie, and Charlie's been chasing us. We haven't had a hot meal, and we haven't had a shower. But Sergeant Major said the 3rd surge needs blood. Can do! And what came to me in that moment was that if they can do, I can do. It's about confidence. Now, the good news is 17, 18, and 19-year-olds have veins like railroad tracks. We are in a fair amount of chaos right now in terms of healthcare. What you guys are working with is incredibly challenging every single day because things are changing very, very fast. However, I'm pretty clear. Nurses can do. And I'm confident that you have the skills, the ability, the critical thinking, the things which you need to help us make a difference in terms of healthcare as it evolves. Nursing's going to have a major role in that. And you can do this. Thank you very much.